Good evening, everybody. Thank you for attending our Paediatric Emergencies webinar this evening. I'd like to begin by acknowledging the traditional owners of the land in which we meet today. I'd also like to pay my respects to elders past and present. So yes, welcome to this evening's webinar. Just a few things about our PHN. The majority of our webinars are recorded and freely available on our PHN Learn YouTube channel. We also have a practice communique that we send out to practices fortnightly with lots of valuable information in that, including an external calendar of events and our internal calendar of events. For this evening's meeting, participants attending will be put on mute for the course of the meeting, and should you have any questions, just pop them in the chat box and I'll ask them on your behalf. It'll be completely anonymous, you won't be named, so yeah, just keep putting your questions in there. Our presenter for this evening is Associate Professor Tim Baker. Please make note of the West Vic PHN health pathways relating to this topic that is on the screen at the moment. I will now hand over to Cara from our health pathways team. She'll speak on this slide and then we will go directly to Tim for tonight's presentation. Thanks, Cara. Over to you.
Thanks, Celine. Good evening, I'm Cara Miller and I'm the Health Pathways Program Lead at the West Vic PHN. Health Pathways, for those that aren't familiar, is an online clinical platform for primary care clinicians, and they contain condition-based guidelines and local referral information. Pathways are written by clinical editors in collaboration with specialists, subject matter experts, peak bodies, agencies, and according to best evidence and in consideration of the local context. So the slide on screen is just a sample of pathways relevant to this evening's content. We also have a large suite of paediatric pathways relative to an array of specialties developed with local paediatricians, and several pathways on high volume, low acuity presentations developed in collaboration with the Royal Children's Hospital. We're also currently expanding our suite of pathways relating to developmental and behavioural presentations in children, so keep your eye out for those. Health Pathways now has approximately 850 clinical, referral and resource pathways available, and the content's only available to clinicians in Western Victoria, and the login details will be provided in the chat and handout and via follow-up email. So that's it from me. With that, I'll hand over to Tim. Thank you.
So the topic is trying to recognise really sick children. So it would be really easy we'd all be really good at recognising really sick kids if we saw about the same number of kids who were sick, say pneumonia or diabetes, and needed treatment, kids that were critical and needed resuscitation, and kids that were just sort of sad and miserable and snotty. So certainly when their mum says, you know, my child is sick, they are right, they have a virus and they're miserable and unhappy, but really they require not much apart from watching them and just checking to make sure they're not sick or critical. Fortunately or unfortunately, this is not the distribution of patients we see. So most people, even in an emergency department, most of the kids that we see are miserable and sad, and will get better with a self-limiting illness that will get better in a couple of days. Some kids are sick and need to come to hospital, but no one sees a lot of critically ill children, and it can be easy to miss them. And we'll have a little video of a child that I came in one morning and saw in the emergency department that no one had realised was sick the night before for several hours. So we're going to talk mainly about assessment at the start. So emergency departments and emergency physicians tend to do things a little bit differently when we assess people. We all learn in medical school that we take a history and an examination, and we form a diagnosis, perhaps some differential diagnosis, and then choose what to do. But in emergency medicine, we don't always do that, and especially not with children. Sometimes, you know, we don't want to go through a whole history and examination because it's important to know at the start whether a child is unwell, to take them somewhere where they can really be seen, or bring them to your clinic treatment area, or to call the ambulance. Also, history and examination are not terribly reliable in children who may say yes to everything or notice everything, or not say anything to anything, or they might be a 2-year-old who just screams every time you come anywhere near them. It's also difficult to try and work out if a 2-year-old or a 12-month-old's got some consolidation on their chest, when you're auscultating, because when your stethoscope's bigger really than the whole chest. And vital signs vary greatly with age. So sometimes it can be hard just off the top of the bat to try and work out if these vital signs are normal. And as we said, experience with critically ill children is uncommon. I think I like giving this talk because my first job as an ED consultant was as a fellow in ICU at the children. So I got to see lots of critically ill children, as well as seeing people in the emergency department that weren't so unwell. So one of the good things, though, about assessing children, especially toddlers, is children who look sick usually are sick. You don't have people who don't have toddlers who are banging it on to try and get a day off work. And usually, children who are sick look sick too. I mean, if you're seeing someone in the first half hour of their meningococcal infection, they're not going to look different from anyone else. But most kids who have a major illness start to look sick. So we're going to talk about a couple of stages of emergency assessment. We're going to talk about an observational assessment that we do from the end of the bed. And this is something I do in still most patients that I see every day and evening in the emergency department, and that's a paediatric assessment triangle, and we'll talk about that. We'll also talk about when you recognise a child being unwell, the physiological assessment we do, the ABCD approach, which you're all well and truly familiar with, I'm sure. And that's to do with, you don't really know how unwell, exactly what's going on with the child. You can treat the things that kill you first, so airway before breathing, before circulation, before disability. This is often used as evidence that God must be an English speaker, in that these illnesses tend to kill you in alphabetical order in English. I don't know how the ABCD works if you're speaking Lithuanian. I've asked various people about that, and they just say they do the ABCD in English, but maybe one day I'll find out there's some other language that does it differently. And the third way to assess people is the classic history examination. We won't be going into that. So we've got a case. We've got a 4-year-old boy who's brought by his distressed mother. He has a cough and noisy breathing, and his mother's on the verge of tears. She says her baby has not been, nose has been running for a few days, but tonight he has not drunk his bottle and he's been awake most of the night. So I'm sure that you've all had cases a bit like this. Cough and noisy breathing, not drinking, and a stressed parent. That's pretty common. Is this child likely to be sick, not sick, or critically sick? Well, I think that's a bit tricky, because I've seen children like this and they're just a bit miserable. I've seen children like this and they've had pneumonia, and I've had a story like this, and when you look at the child is really critically unwell. So it's a kind of classic story that can be either, and it really helps if you can tell from the end of the bed in that first 30 seconds what's going on. So that's what we use, the paediatric assessment triangle. It's an assessment that comes initially from the paramedic literature, and it says we look at 3 things. We look at the appearance of a child, the work of breathing of a child, and the circulation to the skin. And it's done at the end of the bed in about 30 seconds usually, and often can be done just while you're having a quick chat to mum or dad and introducing yourself. And sometimes you do need to do a little bit. You need to get the parents to unclip the grow suit so you can have a little bit of a look at how they're breathing, but it's done really very early on. Now, by the way, I'm very happy for people to ask questions about things as we go. If you type them in, I'm going to be asked them, I believe, and then I'm happy to address them as we go. I know on video conferences people often don't speak up much, but having you all completely muted seems a bit unfair. But I'm very happy to elaborate on anything that you are particularly interested in. So the paediatric assessment time, like we said, from the end of the bed, it's hands off, takes less than 30 seconds and has those 3 parts. So the first thing we look at is appearance, and it has a lovely paediatric sounding mnemonic of tickles. It really should have been in classic paediatric presentation with the font being Comic Sans. And we're looking at the tone of the child, their interactivity, their consolability, look, gaze, and speech cry. So tone is, does the child have the tone that is appropriate for their age? So with a newborn baby, really that's just the ability to lift their arms and legs off the horizontal and move them around a bit. By the time you're getting up to 6 months or so, you really want a child that's able to sit, and later on you want a child that's able to stand and move around. If they're not moving around, that's a bad sign. I'm sure you've heard, and almost certainly many will have seen, children who are described as flat, where they just sort of take on the contours of the bed. And if you see a child and you stick an IV line in them and they don't move, that's usually an indication of something pretty bad's going on. That child is flat. We're really looking, are they interactive? So are they listening to anyone around them and responding in some way? That responding may not be terribly helpful, like that aside you're frightening, or it might be that they're looking at you and they're interested. It might be that they're interacting with their computer game or looking at their big sister. So all those things are interactivity. Consolability is an interesting one. That's usually if there's enough blood going to the brain that they can sort of assess the situation and usually go to their parents for a bit of consolation, since they're in general nicer to be with than the medical staff. It's always and a child who's really unwell just doesn't seem to want to go to the parents or to do anything with the staff around them. It makes you happier when the child is looking around and looking at things rather than just a blank stare. And it's good to have listen to the speech and cry. So, when there's a dad trying to tell you that his child's not breathing and the dad's having to scream at the top of his voice because the child's making so much noise with a roar of a cry, that's a good sign too. A really good solid cry is a nice sign. So that's tickles for appearance. The next thing we're looking at is work of breathing. So certainly they can have some abnormal sounds. And sometimes it's a little bit hard to do because you've got to work out whether they're breathing in or out. But here's a few sounds that you might hear. So good if you think to yourself and think what sound that is. So that's a grunting. So that's where a child, usually a small child, closes their vocal cords to keep their lungs open until the very last part of their breath, and then grunts at the end. So that's kind of similar to an old person with COPD and their pursed lip breathing. They want to keep the pressure in their airways open as much as possible so their airways don't collapse, because it takes less energy to keep them open than to open them once they've collapsed. So that grunting is a really important sign, especially for little children. How about this one? With the loud noise being on inspiration. And that's stridor, and you get that with narrowing outside of the airways outside the chest. And so that's what you most commonly get with croup. You can get it occasionally with epiglottitis. I've seen a few epiglottitis cases in my life, but no paediatric epiglottitis cases since the Haemophilus influenza B vaccination started right at the start of my career. That's been a very good way to prevent epiglottitis. And then there's wheezing, which is the expiratory sounds. You want to listen to those sounds. Fortunately, when a child is really unwell, the inspiratory and expiratory sounds can sound it can be really hard to work out the difference if it's just so noisy the whole way through. But certainly looking for abnormal sounds. We're looking for abnormal posturing. So a child that is sitting up, resting on their elbow so they can use their pectoral muscles to try and lift their chest up. And sometimes you can actually see them try and lift their shoulders and chest up as they're breathing. Most often you see that in someone who's pretty tight with asthma. Or occasionally you can get a child that's got some funny head position and sort of it's the sniffing or sort of sniffing over the fence position a child will occasionally get if they've got an upper airway abscess and they're trying to keep that airway open. And then you've got retractions. So when children are trying to generate a lot of inspiratory pressure, they will suck in their very compliant chest wall. So you can suck in the tissues above the clavicles and above the sternum. They can suck in between the ribs, and they often do. Even really chubby babies can get, that 12, 18 months, can get some intercostal recessions. And you can sort of get it below as well. Sometimes there's so much sucking in going above the airways that the head starts to bob. That sternal recession, like that picture there, where the breastbone almost hits the backbone, is really very concerning. When you consider that in cross-section, we look at a CT, not that we CT children, but very much, but the spinal cord sort of takes about a third of the way between the sternum and the bed, and they're sucking their chest in halfway. There's really not much room there for the heart. And some kids, when they're really working hard, will just about seem to be sucking that sternum back onto their backbone, so chest bone onto their backbone, which is a concerning sign. And then you've got some nasal flaring. So much like racehorses, little kids will sometimes flare their nostrils. And this kid looks like he's just dirtied his nappy and doesn't like the smell of it. But the flaring of nostrils, which really best seen on a video than a still picture, is something that can happen and will show that they're really working hard to breathe. So for circulation, we're looking for pallor. We're looking for mottling. So mottling can happen in little kids anyway, when they're like neonates, when they're just not got their the neurovascular system sorted out, so they can dilate and constrict their vessels in the appropriate ways. But when children get sick, they get that mottled appearance where they start opening up blood vessels when they really should be closing them down. And cyanosis, of course, if you've got a significant percentage of deoxygenated blood. So I'm going to talk about a case. This is a case that came in with that description before. Not feeding very much, having a little bit of a runny nose, mum really stressed. They got in there about 5 a.m. They were all racked up. The registrar overnight said, well, their SATs seem to be okay. We'll just keep them for the morning and we'll see what they're like. I'm going to play this little video and see what you think. See which of those signs. So you can think of your tone, interactivity, consolability, look, gaze, and speech. You can look at your abnormal posturing. You can look at your retractions. You can look at breathing noises, although you'll hear mainly the sibling of this child in the background. And you can't really see, you might get a little bit of nasal flaring, but I actually don't think, I think I've sort of cut that off in the video. And you can look at tone, look at color. So whether you've got pallor, cyanosis, or mottling. Here we go. I'll leave it for a few cycles through if you have a look. So let's have a look at that tone. How much they're moving around. Are they interacting? Consolable. And this is a fairly small child, so some of those things not too much. Are they making much noise? And then look at breathing. So particularly look at work of breathing and retractions. Both are on the left-hand side in between the ribs, and look at that, especially now on the right side, just above the sternum. Okay. So hopefully what you saw is that child had poor tone, really not much interactiveness, not looking around, no speech or cry, and really was working hard with a little bit of grunting, which is sort of saw by the sort of that sort of jerky breathing more than you could actually hear it as well there, and lots of retraction. So certainly retracting above the sternum, and certainly retracting in between the ribs. But the circulation to the skin was good. They looked nice and pink. So just having a look at those components can give you a little bit of an idea that this child is unwell. So basically you had poor, not a fantastic appearance, and you had increased work of breathing. So those kind of things would be what you would see if you're getting into respiratory failure. But they're not really moving on to cardiorespiratory shock, in that the circulation's still good. They're still pumping blood around and still managing to keep things pink. If you've got a child where the tone is bad and the interactivity is bad, but there's no increased work of breathing and the skin looks warm and pink, then you've really got some kind of neurological problems going on. Maybe the baby's had a seizure, maybe they're hypoglycemic, maybe a metabolic problem. When you've got, which occasionally you'll get, a child who's breathing okay but is really very mottled and cool with poor circulation, you might either be moving into some kind of cardiac problem, which you can have some cardiac abnormalities that are undiagnosed at birth, or they're less now, so now that there's more ultrasounds, or they're becoming septic. Although usually as children get septic, their work of breathing increases as well. Certainly their breathing rate, as they breathe harder to make up for a bit of metabolic acidosis and a bit of lactic acidosis. And when you've got poor appearance, poor work of breathing, and poor circulation of the skin, this child's moving towards cardiorespiratory decompensation. So I hope that you will consider trying this. I certainly do it almost every patient I see. If one of the registrars seen the patient and they say, I've seen this patient and they're really, really fine, but I just can't work out what this spot is on their right elbow. Well, I don't do this. But for most patients I see where they've come in with some kind of undifferentiated illness, I do this at the front. I introduce myself, and while I'm doing my little spiel, we all have our little spiels. I chat to the parents. I'll have a look, and usually just get if it's a little baby, the grow suit up or the clothes. I just have to see a little bit of the ribs. Often, if I'm often because I have junior doctors with me, I'll actually say out loud what I'm doing, and at the end of it, I can say to the parents, well, we're looking good here, the breathing's fine, the circulation's fine. They're obviously unhappy, so now let's go and find out all the details. But I really like to know in that first minute or so whether this child is really sick, and I should be saying, I'm not as happy here, let's get some high flow oxygen, let's move the child to resus, or whether we're just going to move along with our normal kind of assessment. So this is sort of what I do. This is basically either the child turns up, you look at them and their paediatric assessment triangle is normal, so just go into history examination. If it's abnormal, then I'm thinking that I really need to get on and treat this child even before I've got a really complete history examination, and I'll go through an ABCD approach. So that's what we'll talk about next. But before I do that, has there been any questions about the first part, that paediatric assessment triangle? Or does anyone want to type in a question?
I haven't got any questions at the moment, but if there's any comes in, I'll certainly interrupt you.
Fair enough. That means one of two things. Either, you're you're incredibly aware of this, or there's stunned silence, or you've all gone to sleep, I suppose. So it actually could mean many things. I'm glad to actually hear one voice speak, because for a while I wasn't sure whether anyone was listening at all. I think lots of the GPs in this phone on this webinar are pretty experienced and will know a lot of these things. And all this will do is just give them a little bit of a framework to hang their many experiences on. But you know, all I can say is I find it useful. So next, move on to the A, B, C, D, E approach, where people seem to add more things on as we go. So in general, as we all know, it's airway, breathing, circulation, disability, and exposure. And another one I like usually is don't ever forget glucose. That's a great way to be really stressed that a child's really unwell, and or an adult's really unwell. Find their glucose is low, fix it up, feel like a hero. It all goes well. So I'm going to talk about some of these things that are different. If you're working in an urgent care centre as a general practitioner, you're probably going to do more of these things than in a general practice, but you might be doing some of those things while you're waiting for the ambulance. And I always think that whatever your job, you need to know your job, and you need to know the next step of everyone else's job to know, you know, whether they're doing the right thing. So when the paramedics come, you know, when the patient goes to ED, you want to know, you want to have some kind of idea of what they're going on, so you can tell the parents, so you can see whether they're doing the right thing. So children, of course, they have a few differences. The main difference is they have a pretty big head and a pretty tiny face, which really changes where their tongue is. It sits high, and their larynx sits higher. And the fact that their head is really big means that to get a good position to intubate an adult, we often put a towel behind the patient's head of an adult, so they have the sniffing over the fence sort of position. But for a child, we do the opposite. We put the towel under the shoulders, so the big head can sort of go over the top of the towel, and it stays in a neutral position. And that's why when you look at all the little humidity cribs, they've got the little depression. So originally I thought, because the babies were, when I was a student, that the babies were really very slippery, and that the viv was to keep the head in so they didn't slip around the cot. But no, it's actually to keep them in a nice anatomical position. So for airway assessment, you're really looking for their head and neck position. Are they holding it in a funny way because they've got some kind of obstruction there, and then they're sort of instinctively keeping it in an open position. And one of the things I would say that may never affect you at all in your career, but if you have a child or an adult who's got themselves into a funny position and they've got some kind of airway problem, certainly don't lay them flat, because they've got themselves into that position because that's the position that keeps the airway open. And you certainly don't want to lay them flat too, because that will make things easier for you, because in the long run it'll make it much harder for you if they lose that airway. So you're looking for stridor, you're looking for that hot potato kind of voice that people can get if they've got some upper airway swelling. You're also looking for things that block the airway, like secretions, vomit, foreign bodies, bits of Lego, you know, all the kind of things that children can have. So airway management in the general practice is basically going to be either let them stay with the position that they like, or you can do some kind of positioning where you try and keep them in good alignment, which is sort of the mastoid process in line with the sternal notch, which as they get towards adults is a towel under their head, and and when they're neonates is a towel under their shoulders, and in between is in between. You might do some gentle suctioning, but it's very easy if you've got some, but it's very easy to make the airway bleed in a child. You can use oral or nasal airways in a child as much as you do in an adult, but you don't do the classic putting the Goodell's airway in upside down and twisting it around, because it can make the airway be damaged and bleed and swell. laryngeal masks, and of course, eventually they're going to be intubated. If you're the GP anaesthetist and there's someone a long way away, you might do that. You might take them to theatre and gas them down gently for a croup. But I imagine if you're going to do that, it's going to be a day you're going to remember for a while. And I imagine most people are not going to want to do that. I certainly don't want to do that. But, every now and then you've got to do what you don't want to do. The main airway problems are going to be croup. And often when kids come with really noisy breathing and you can't work out if it's, and people say, I'm not sure if it's asthma or it's croup, it's usually croup. We would use nebulized adrenaline. Certainly with COVID, there's a bit of an idea that we shouldn't be nebulizing anything. So if you wanted to get advice, that would be reasonable. But certainly most emergency departments, all emergency departments, are still using nebulized adrenaline. There's a foreign body, then there's that you remove it, or if they rest follow the foreign body guidelines for that with the back blows, etc. If they're unconscious, you're going to position that airway, and of course, if they've got some of these terrible epiglottis or abscesses, you really want anaesthetist to give you a hand. Certainly, they're all array of congenital things, and I hope you never see them intubating children with Pierre Robins. I've only done in ICU with the very tiny faces. That's all very difficult, and I'm very happy to leave that to specialist paediatric anaesthetists.
I have a question, Tim.
Yes.
Would you have a specific question or questions you would ask a nurse on phone triage to seek further clarification when parents ring with a sick child, for example, runny nose, cold, fever, etc.?
So there are some reasonable guidelines on this. The only real guidelines I've ever seen anyone stick their name to for phone advice. So the National Institute of Clinical Excellence in their Feverish Child Under 5 has a section on assessing the child over the phone and decide, which is it's a British set of British guidelines, British government guidelines, and it gives you some questions to ask. Those questions would normally be things like some of those appearance, behaviour, all those kind of things. But those questions can be very difficult because the mum will say, or dad will say, well, they're not like usual. They normally run around all over the place. They're not running around, which that's true, but it's not flat like when you see a really flat child. And they ask questions about eating and drinking, noisy breathing. I think if you can see a child, because you're doing a video conference, pretty much all of that paediatric assessment triangle, in fact, all of that paediatric assessment triangle can be done over video. Absolutely. If you get to video, do a video assessment. So I would say, not that, you know that emergency departments just say, well, come to the emergency department, we're not going to give you any advice over the phone. But I would say, have a look at that Feverish Child Under 5 from the NICE guidelines if you want to read something about that. But if you're looking at a child over the phone and you want to be happy that they don't have a critical illness, then I would do that paediatric assessment triangle. Is there a follow-up question from that?
No.
Does anyone else have any pearls about how they decide? When I've done a lot of work in international retrievals, and I think actually, over the telephone, if you can actually have the person you're assessing when they're a bit older speak to you, like if you've got a 7 or 8 year old and you can actually speak to them, you can get some kind of idea by how they respond. But there must be people who've done this in general practice for a long time. Does anyone have any pearls they want to share about how they assess any go-to things to work out if a child's not well?
Just a follow-up from that same person, just to say that no follow-up, but it's just hard with COVID and colds these days.
It is. And assessing a child over the phone is the same. I think that in general, most children are not going to have COVID or not be seriously ill from COVID. Because it's the problem of the silent hypoxia, so maybe they wouldn't have as much increased work of breathing as other respiratory illnesses. But I think that's sort of really kind of a theoretical question. I think if you can look at that, if their tone's good, they're sitting up and looking around, they're interacting with mum, they're looking at what's going on the video screen, they're noisy, or they're either talking or crying. If you can see what posture they've got no retractions, you can listen and see if they've got stridor and look at the colour of the skin. I reckon, it's meant to be an end of the bed assessment, so I think a telemedicine assessment is also a good way. Never really thought of it as a telemedicine assessment. I have to have a bit more of a think about that. Okay, any other questions or any other pearls people wanted to mention?
Not at this stage.
Okay, so let me go on to breathing. Certainly, children have a high metabolic rate and about the same tidal volume percentage-wise for breathing. So, they produce more carbon dioxide because of a high metabolic rate. Each breath's about the same size relatively, so they've got to breathe faster. So the smaller you are, the faster you breathe. And sometimes it's hard to remember. I imagine people have stuff in their clinics that gives them the normal breathing rates. If you're in an urgent care centre, there's the Victor charts, which are the Children's Hospital observation charts. There's specific urgent care ones that you should have, that you can put the obs in for the various age groups, and you'll see if they're inside or outside the normal parameters. One of the things that really is a bit stressful about children, in a couple of ways, but certainly respiratory, they don't have many slow twitch fibers, so they breathe, and all of a sudden they'll fall in a heap. And like kids do normally, they run around everywhere, and then all of a sudden, if they've run around too much, they just sort of stop. And so they can be breathing fast, and very quickly stop breathing. And when a child stops breathing, the time it takes to drop their oxygen is really short. So even when you intubate or when they stop breathing, it only takes 20 or 30 seconds for them to drop their sats from 100% down into the 80s and 60s. So that's always really scary. If you've got a well-oxygenated adult, they will keep their sats up for a couple of minutes once they stop breathing, but certainly not a child. For breathing assessments, you're going to look at some of those things: sounds, posture, nasal flaring. You're going to look at the effectiveness of breathing by just seeing the chest expand, hearing if air entry is coming in, so you've got any focal signs. And you're going to look at the effect of breathing on other organs, like are they tachycardic, their skin nice and pink, are they nice and awake? So for management, you're going to allow the child to find the best position for breathing. Often there's that tripod position where they use their pectoral muscles to help them breathe. You're going to be able to give oxygen if they're hypoxic. You're going to be able to give ventilation if they're really unwell, and then there are some specific therapies as well. Certainly as children start to get into hospital, we can give nasal prongs, and then we can move to high flow humidified oxygen with a setup something like this, which some urgent care centres have, but most don't, but some certainly do. Certainly gives you a bit of positive end expiratory pressure, but does some other things like decrease your dead space, breathing dead space. And really that can be amazing. You see the child who's really sucking their chest in, and you put them on that, and that immediately settles down. And then there's circulation. So it certainly is appropriate to measure the blood pressure of a child if you think that child is septic or has a cardiac problem, or is hypoxic, or you think has a renal problem, could be hypertensive. So generally, you can do age times 2 plus 70, although most people again would look at the Victor charts or something similar. The one thing also to remember about children with sepsis is never trust a good blood pressure, because a little bit like they fall in a heap with their respiratory signs, they can fall in a heap with blood pressure too. So a child can maintain their blood pressure while being very septic, and you're waiting for the ambulance to come, and you go and have a cup of tea, and you're just going out there, and they say, I can't get a blood pressure anymore. So they fall in a hole really quickly. So usually the definition of sepsis for a child is usually tachycardia and poor perfusion rather than a blood pressure based definition. You're going to have a poor capillary return, despite the fact that no one seems to be able to design an experiment that shows that capillary return works really well. Almost every clinician uses capillary return, and it seems to be a useful part of their armamentarium. So if it's taking more than a few seconds, usually I do it on the chest because that's got more central circulation than the feet. But occasionally you put your finger on, you take it off, and 5 seconds later there's nothing much there. Then that's not great. What we're going to do if you're in the urgent care centre is you're going to give some fluid boluses of about 20 mils per kilo of normal saline. So, and with an easy IO is usually the way that it's done now, rather than with the hand drills. And you get a syringe and a 3-way tap, and you can syringe in some fluid. But if you're at that stage, hopefully you're on the phone to Piper and they're telling you all the right things to do. Or if you're in your general practice clinic, ambulance arrives before you need to be doing things like that. They certainly have easy IO or something similar, and but I think it might just be mica rather than the ALS cruise. The disability looking for their conscious level. You can try and do a GCS. And there is out of 15, and there is a paediatric GCS Glasgow Coma score that I have seen. That's one of the stages is children are irritable, which I think would have had all my children having a low Glasgow Coma score at the end of every school day, or around 4 to 6 in the evening before they had something to eat. So perhaps it's easier to do when you're looking is just do AVPU. Are they alert, respond to voice, pain, or unresponsive? And some people would say AVPU-PU, which is, AVPU-PU, or AVPU, which is pupils, and you can have posture in there as well. So alert, voice, pain, unresponsive. What are their pupils like? What's their posture like? And exposure, looking for rashes, injuries, non-accidental injuries. In a small child, non-accidental injuries can present in a really very non-specific way. And temperature, which includes keeping the child warm while you look at them. So in our summary, just for the ABCD section, we're going to treat problems in order of life threat. It would also, just as a summary thing, say, while the ABCD says you treat them in order and only proceed when one problem is solved, if you've got a couple of people there, you can do all stages at the same time. You don't really need those vital signs to start with, but you just need to know whether the child looks sick and if they're working hard to breathe. So in our conclusion, which I think which is about, the talk's taken about 50 minutes, which is about the concentration span of an emergency physician if they really work on it. Look at the pediatric assessment triangle, which has 5 things for appearance: tone, interactivity, consolability, look, gaze, and speech. 4 for work of breathing, which is abnormal posturing, abnormal sounds, abnormal retractions, and nasal flaring. And 3 for skin changes, which is pallor, mottling, and cyanosis. When you decide a child is really sick and unstable, then you would go through your primary survey, airway, breathing, circulation, etc. Okay, so I think I can stop showing my screen now and see if anyone's got any questions.
I don't have any questions that have come in, so if you've got any questions on anything you want to ask Tim, please put them in the chat box in the next couple of minutes while we've still got Tim with us. I'll just give you a little rundown on some education that we've got coming up. First of all, don't forget to fill your evaluation out for today. Any topics, future topics you might have, emergency topics. Tim's got a whole heap of presentations that on all different things. He might be able to give you a little background on them if he wants. We've got our obstetric emergencies coming up on the 28th of April. We've got a rural and regional GPs emergency skills workshop in Stawell on the 8th of May. That's open to any GP within our region. That's an all-day one. Topics are ophthalmology, burns, first aid management, ENT emergencies, musculoskeletal emergencies, alcohol and drugs of addiction. There's CPD activity points associated with that, but not a like a 40 category point one. It's based on the ARC guidelines, but it's not an accredited course. There's no formal skills that will be assessed there. So that's happening in Stawell. You'll find the details on our website if you've got any questions on that. Other than that, could I thank Tim? Tim, do you want to finish off with any words to say before we finish? And thank you for such a great presentation.
No, I can say that, even though we're talking about, it'd be nice to work out which kids are critical and which are sick and not sick, this is not the cut point of whether you should refer the children or not. We don't expect you to know immediately at one visit whether the child's really sick or not, and we're very happy for you to send in children that go home. In fact, most children who come in end up being not too sick and go home, but not that we're happy to say that on our first look at them at triage either. So certainly you can send. And we all know that children exist to embarrass you. So the child looks really sick with you in the clinic and then turns up at the hospital and looks completely well, and you think people are going to think really silly things about me. But I can tell you, when I was an ICU fellow in the children's, my child had croup and looked really terrible at home, and I rushed him into Monash Medical Centre, where he then looked completely well, and I looked completely stupid. And that's just what children like to do. That's the way it is. If you're worried in any way, very happy to see any children, and most people are. And if we're worried in any way, we'll talk to the paediatricians too. That's it's our best way to keep people safe. So still no questions?
Yeah, I'm interested. Yeah, I'm interested in advice to give parents if you are asking them to call 000 and what to do.
If they call 000, then the person who answers the phone for 000 will go through the algorithm and will give them advice, and that advice will be, to put the child in a comfortable position and all those kind of things. I'm not sure that there's much specific advice. I do see, most kids don't come by 000, but I think if you think the child is unwell and you want them to call the ambulance, then I think it's very unlikely that any emergency person is going to tell you off for that. I reckon that's I think that's a reasonable thing. What would I tell them? I would just say that, I know you could drive to the hospital, but these conditions can progress rapidly, and a child can get really sick quickly. Once the ambulance is there, they can give lots of the initial treatments, and I think it'll be safer for you and your child to go by ambulance.
Another question, is there anything that GPs often miss?
So I think there's something that in a lifetime people will miss, and that people should, will feel terrible about it, but don't. So a couple of times in my career, I've had to ring GPs and say, remember that patient, that child you saw yesterday with a mild fever. They've come into the emergency department and they've died of meningococcus or some horrible infection. And that's a bad phone call to make and a worse phone call to receive. But in none of those cases can I really say that the GP has done anything wrong. Really early on in an illness, even a terrible illness, those first couple of hours, it's very hard to tell any undifferentiated fever from any other one. And if you're sending every single child with a fever for assessment, you're not doing the right thing. So I think, everyone will miss a child who is sicker than you think they are. And that's why you need to have a good safety net. You need to say, you know, this, you know, your child looks well, but if anything changes, you know, call me back in the next few hours or go straight to the emergency department, because it's just not possible to differentiate really early things. In general, I think that GPs are cautious with children and refer them appropriately. They've got no real concerns.
Another question. How much adrenaline do you give when nebulized?
So this is the weird thing. The dose for angioedema and the dose for croup is pretty much the same, because if you're big, you breathe in a lot, and if you're little, you breathe in not very much. It's usually about 5 milligrams. And I think people have got the very sensible idea that if you're opening up multiple vials of things, you're doing the wrong thing. But adrenaline, which comes in 1 milligram vials, you're opening up multiple vials to give the dose, and it looks frightening. You're giving, you know, 5 times the dose you give for cardiac arrest, but most of it's just disappearing off into the air. So I would say get out the protocol and read it, or read the children's protocol when you're doing it. But just know that it's quite a lot, 5 milligrams, and that's, you know, it's frightening the first time you do it, but that's what's always done.
Okay, no other questions. So thank you, Tim. Just a comment from, oh yeah, there is another question, but just a comment from a GP. Thanks. Good structure to follow with the triangle. Very helpful refresher.
Yeah, I reckon most GPs will know this stuff. I mean, all experienced GPs over the years have seen this stuff. It's just I just find it a nice framework to hang things on. And if you look up Paediatric Assessment Triangle, there's plenty of stuff on it anyway, just as a way of just arranging the stuff you already know.
Okay, and just another question here about a 12-month-old with wheezing, query, asthma first onset, PAT, only circulation okay, triple O called and spacer with Ventolin given. How much Ventolin?
Usually we just go with the 6 puffs under 6 and 12 puffs over 6. And again, if you're little, you breathe in lots, and if you're not little, you breathe in less. It's always really annoying, isn't it? Because people say, you know, 12 months of under, it's going to be bronchiolitis, but you know, as soon as they're not getting better, someone will try Ventolin. So, but that's usually the way that I work.
So it's just got as in more than 4 puffs at a time.
Yeah. So I just use the children's ones, which I'm pretty sure 6 puffs under 6 and 12 puffs over 6.
Okay, fantastic. Yeah, just another comment. Fantastic presentation. Thank you, Tim. Excellent presentation. Thank you. That was from someone in Lorne. So look, quite a few of our region GPs clocking in tonight. Yep, so thanks again, Tim. Fantastic.
Good. I'd be interested if people do feedback, just to make sure I'm hitting them. If I do some more of these, that I'm hitting the right level for, because what you need to know in the clinic setting and what you need to know if you're covering the urgent care centre overlap a lot, but they're not exactly the same.
Yeah, that's great. Thanks, Tim. And yes, please put in your comments anything that you think, and I'll certainly pass it on to you, Tim. Okay,
no worries.
We'll end it there. Thanks, everyone. Thanks, Tim.
Bye.